Very good evening, friends. At the outset, we all thank the SPEEDCON organizer for bringing us here. After this covidization of society, we are meeting after a gap of 2-3 years. We were meeting on onlines, but today it's a nice occasion to have you all live here together. So for the first session is by Dr. Samir, and he's going to take us with a case scenario of renal calculi. And just I want to, Samir, you can come on the dais. So can we have CV of Dr. Samir? So renal calculi, most of the time we see that patients come to us in OPDs, and we used to refer them for ultrasonography, and the patient goes to a urologist or a surgeon, and he goes for some intervention or some sort of surgical intervention, and we never think that there is certain cause behind these renal calculi. Why this young man? Why it is having bilateral? Why it is renal and also gallbladder? Why it is nephrolithiasis? Why there is nephrocalcinosis? So these are the things which we should highlight in our mind, and I know that Samir is going to give us more light on this topic. So over to you.
Thank you, sir, for nice words. Welcome to SPEEDCON. It's always a pleasure to be speaking in front of your teacher, and I'm honored that one of the chairpersons, Professor Harpreet Singh, is my teacher and chairing this session. Thank you, sir. It's really my honor that you are here, and we are honored to have some senior faculty from Government Medical College, Chandigarh. Also, Dr. Atri is amongst us in this hall. Thank you, sir, for joining. Past President of API, Dr. Verma, sir, SL Verma, sir, thank you. And so many seniors from Gurgaon, Dr. Taneja, thank you, sir. And Dr. Suri, who taught us in our undergraduation days, and in fact, we learned the art of history taking an examination and approach to medicine cases from Dr. Sandeep, bedside teaching. Thank you, sir, for joining. So this is an interesting topic, I think, which the workup of renal calculi, which I think we didn't, this subject we learned when we were doing our DM in our All India Institute of Medical Sciences. But I think, yes, it's very important, as Dr. Suri was saying. So is this normal, since most of the cases of renal calculi are dealt by urologists or general surgeons, and physicians also encounter these cases, but we usually write some painkillers and refer them to surgeons or urologists. But do these patients who have renal calculus, do all of them require some workup, some metabolic workup? So my talk is basically concentrated on metabolic workup, or you can say endocrine evaluation of renal calculus, especially recurrent renal calculus. In fact, any patient who is having recurrent renal calculi, children having renal calculus, any patient who is having some systemic manifestations along with renal calculus, these are few group of patients who would definitely require some metabolic workup. So I will come to this index case towards end of my talk, but this was the prototype case, like 32-year-old male, pain abdomen, and was found to have renal calculus, recurrent renal calculus. In fact, bilateral renal calculi or recurrent renal calculus, you must be alert that maybe some patient is hiding some underlying disease, because until and unless you are taking care for some underlying metabolic abnormality or some systemic abnormality, if you operate these patients or take out the stone, again they will develop renal calculi. And it's very important to address renal calculus, because the studies have shown clearly that recurrence of renal calculi will cause decrease in GFR over a period of time, and patients can land up into chronic kidney disease. Most of the calculus are, you can see this blue ones, these are calcium oxalate followed by calcium phosphate, and yes, you can have these struvite stones, cystine stones, or other stones also, but most of them are either calcium phosphate or they are calcium oxalate stones, as the stone analysis studies have shown. So this is what I am talking about. Which patients will require metabolic evaluation? Recurrence of stones, skeletal fractures, some lytic lesions on X-rays, they will require some workup. osteoporosis along with renal calculus, maybe some there is hidden abnormality, family history of stones, personal history of gout, and stones composed of cysteine, uric acid or calcium phosphate. So these group of patients will require metabolic workup. So what should be the normal serum calcium in the blood? This I think we sometimes ignore in the biochemistry. We write it as normal, we pass it as normal. The standardized values, normal range of serum calcium should be 8.1 to 10.4, 8.6 to 11, 9 to 12 or 10 to 12.5. Normally it should be 8.1 to 10.4 milligram per deciliter. Of course there is a catch to it. Whenever you are checking serum calcium, the most important thing along with calcium is to do a serum albumin also. The formula is simple, 0.8 into 4 minus serum albumin, you add to the current value of serum calcium, that will give you the correct value. Sometimes patients have hyperproteinemia, so you can have false low values of total serum calcium. So you must always do a albumin along with calcium, only then you will be able to make out the corrected serum calcium. The biochemical risk factors. So these are the various risk factors like high serum calcium, high urinary oxalate, high urinary pH, high urinary citrate. Which of these is not a risk factor for renal stones? These are few metabolic abnormalities which we encounter. Interestingly, high urinary citrate is a protective factor for renal calculus. If you have a low urinary citrate or hypocitraturia, then you can have renal calculus because citrate is an inhibitor of calcium oxalate and calcium phosphate. And we have shown that the maximum stones are either calcium oxalate or they are calcium phosphate. High serum calcium as occurred in hyperparathyroidism can cause renal calculus. High urinary oxalate, either it can be some genetic disorders leading on to primary hyperoxaluria, inflammatory bowel disease, malabsorption. Recently, some surgeries predisposed to hyperoxaluria done in obese patients. These are metabolic bariatric surgeries. Why do they cause hyperoxaluria? Another interesting concept is that patients who have undergone specially jejunal ileal bypass, they have increased in the fatty acids in the lumen, which binds free calcium, and calcium binds oxalate. So once you have decreased in the serum calcium in the gut, it causes increased oxalate absorption and from the gut into the blood and causes hyperexuria. And also some bypass surgeries cause increased permeability to the oxalate from the gut into the kidney. So you can have high urinary oxalate because of these bariatric surgeries or bypass surgeries also. High urinary pH, especially in renal tubular acidosis or other causes, can cause calcium phosphate. Calcium oxalate is usually not related to any disturbances in urine pH, but calcium phosphate, yes, once you have high urinary pH. So what should be the cutoff for the urinary pH to promote calcium phosphate stones? Usually the studies have shown should be more than 6.5. There is one condition in which low urinary pH can also cause renal stones. If your urine pH is consistently coming less than 5.5, usually sometimes there is precipitation of uric acid crystals. Short of this condition, mostly if you have a urinary pH which is high, it will cause urinary stone formation. So hypocitraturia, you can have so many conditions, RTAs, chronic diarrheas, UTIs, and carbonic anhydrase inhibitors. Neurologists are particularly using these drugs. One of the common drugs is topiramate, which can cause renal calculi. So whenever these patients are on anti-epileptic drugs like topiramate, we must do a periodic ultrasound kidney urine so that they do not form renal calculi. Of course, you can have this deficiency of cofactors in oxalate metabolism, which can cause hyperexuria. So like I told you, it's very important to treat and look for the etiology of recurrent renal calculus because it predisposes for decrease in GFR and development of chronic kidney disease. And particularly hyperexuria is very detrimental for your nephrons. It causes CKD. Many patients can land up into CKD during later years. So, lot of things about diet and stones. So, which is associated with increased renal calculus? Low calcium intake, low animal protein, low sodium diet, or high fluid intake. In fact, high fluid intake is always protective for the renal calculus. So, out of these choices, in fact, low calcium, in fact, this is a paradoxical which we sometimes feel, is that I have seen, and maybe most of you have seen, that patients of renal calculus, they will tell you that they are not taking milk or calcium in the diet because they have renal calculus. So, this is paradoxical once you have low calcium in the diet. So, why does low calcium can predispose to renal calculus? So, this is the basic concept, that once you have good calcium intake from the diet, it binds oxalate in the gut and decreases the absorption of oxalate. So, low calcium will predispose to increased absorption of oxalate from the gut and causing increased renal calculus risk. Other reason can be that once the patient are having low calcium in the diet, that can sometimes promote hyperparathyroidism also, secondary, so that can also cause it. But usually low calcium promotes hyperoxaluria, high animal protein causes increase in calcium and uric acids, high sodium diet also causes hypercalciuria, and low fluid intake usually leads on to lithogenicity. So, there can be some endocrine etiologies, like hyperparathyroidism is one of the common causes for recurrent renal calculus. Idiopathic hypercalciuria, because of gut absorption, increased gut absorption of calcium from the intestines, increased bone resorption, increased renal losses. So, you can have many causes for idiopathic hypercalciuria. Renal tubular acidosis is again one of the interesting things, especially when we see patients who have bilateral renal calculus, hypokalemia, acidosis. Sometimes it can be subtle acidosis like pH around 7.2, bicarb of 13 and 14, and patients suffering from renal tubular acidosis. So, very interesting area where you need to have a good workup, good endocrine evaluation, that whether it is one of the causes for hypercalciuria or renal stones. The studies have shown that maybe incidence of renal calculi is more in males as compared to females, especially once you cross age more than 40. Below that, the incidence seems to be quite same between males and females. Maybe androgens playing into some role. This is one of the studies where they have shown increased testosterone or free testosterone in patients versus controls. The etiology that testosterone is suppressing osteopontin expression, causing increased urinary oxalate excretion. Obesity promotes increased renal calculus, maybe increased uric acid secretion into the urine. Diabetes, especially poor glycemic control, again causing increased levels of uric acid into the urine, hyperoxaluria and maybe hypercalciuria, causing increased formation of stones. So, which of the following is not associated with uric acid stones? I think most of them are associated with increased incidence of uric acid stones, whether it is obesity, chronic diarrhea, or gout. And we must remember that uric acid excretion is highest in infancy and remains high relative to adult values until adolescent. So, once you encounter recurrent renal calculus, you want to rule out any systemic abnormality or endocrine abnormality. These are the basic investigations, of course, hemogram, renal function tests, ultrasound, KUB. But serum calcium, albumin, phosphorus, vitamin D, PTH, and electrolytes. These are very important investigations from endocrine point of view. So, why do we need to measure phosphorus? Sometimes this is one of the, I think, ignored element in our investigative workup. We must remember the normal range of phosphorus. Usually they are high in adolescents and children. Hypophosphatemia with hypercalciuria, there are a couple of conditions which can cause bilateral renal calculus or in fact recurrent renal calculus. Hereditary hypophosphatemia, primary hyperparathyroidism, and density juice. So, there can be tubular disorders. Increased 125 vitamin D, usually we do not measure, but sometimes patients of sarcoidosis, lymphomas, or granulomatous disorders have this increased calcitriol, and once you have increased calcitriol, it causes hypercalciuria. In fact, many of the calcium tablets will contain calcitriol, and as endocrinologists, we always say avoid using calcitriol. It's a very potent drug which can increase the calcium absorption from the gut, leading on to hypercalciuria and stones. So why electrolytes are important in the workup of recurrent renal calculus? Because hypokalemia can guide you towards many disorders. It can guide you towards tubular disorders like Bartter syndrome. It can suggest you that maybe you are not missing at renal tubular acidosis. In fact, we encountered couple of patients of renal tubular acidosis with hypokalemia and found to be suffering from autoimmune disorders. So how do we prove it? We do a urinary acidification test. You can do with ammonium chloride or Lasix and fludrocortisone. Urine tests are very important in workup. Again, this is one of the ignored areas. It's not urine routine which is important in workup of renal calculus. It's 24 hours urinary calcium and creatinine. Why creatinine? We always say go for creatinine because that guides you whether there has been adequate urine collection or not. Usually the range for creatinine should be 10 to 15 milligram per kilogram. If it is below that, it usually tells that maybe the patient has not collected the urine in a proper way. If the patient is having active UTI or has been some recent obstruction or hydronephrosis, it can give false or erroneous values. We avoid going for 24 hours urinary collection in these conditions. We must remember these cutoffs. You can always keep on your phone that calcium, you can say that 4 milligram per kilogram per day should be the upper limit of 24 hours urinary calcium. So similarly, there are cutoffs for uric acid, oxalate and citrate. No one can remember, but yes, these are the rough cutoffs. So if you have a citrate which is less, it is risk for stones. If you have hyperoxaluria, again it's a risk for stones, and uric acid cutoffs are like this. These are the parameters in children and adolescents. And important thing is that do not rely just on a single 24 hours urinary collection. It should always be multiple, at least 2 24 hours urine collection should be there for the metabolic workup. Yes, there is evidence to it. The studies have clearly shown that once you are going for more collections, then the pickup rate also increases. So always go for 2 urinary samples at maybe interval of couple of months. So this was our index case, 32-year-old male. He was around 60 kg, pain abdomen, and was having recurrent renal calculus. So that was the patient which was referred to us. He didn't have any history suggestive of headache. Injectable vitamin D, which is one of the commonly used drugs. Injection vitamin D we usually avoid because it's around 6 lakhs, so gives lot of vitamin D at the same time, and we have seen occasionally cases of hypercalcemia and hypercalciuria because of that. No history suggestive of periodic muscle weakness, no history suggestive of any hypertension. Patient had underwent PCNL surgery around 5 years back also, but was not evaluated from metabolic point of view in spite of clear history of recurrent renal calculus. If we see the calcium, sometimes we miss at these values of 10.8, 11 and 11.2. These are not normal values. This is increased serum calcium, and whenever you find increased serum calcium, you must do of course concurrent albumin, but there is no doubt that this is hypercalcemia. I forgot to mention phosphorus. It was around 2 in this patient, and PTH was high, 152. Usually at the background of 11.5 of serum calcium, you must have a lower PTH. So by checking at PTH, you can tell that whether it is PTH dependent hypercalcemia or independent. Vitamin D level was not that bad, and 24-hour urinary calcium was around 360 milligram per day, which was raised both according to total cutoff or 4 milligram per kilogram per day cutoff also. This was the bilateral renal calculus, and patient was also having scoliosis, plus there was a lytic lesion in the long bone. So immediately it came into my mind that maybe we are dealing with hyperparathyroidism. We went for a parathyroid scan, which clearly showed a right inferior parathyroid adenoma. In fact, this was the basic systemic abnormality for the patient, leading on to hypercalciuria, recurrent renal stones, and hypercalciuria also. So this patient was operated. right inferior parathyroidectomy was done, and this patient has not developed any stones after that and is doing very well, and some body aches also have gone down in this patient. So this is a flow chart that if you have a struvite, usually long-standing some urinary infections can cause these stones. If you have a increased in uric acid, then you have to work up according to that. Cystine stones are usually hexagonal, and if you have this calcium oxalate and phosphate, I think we must do a metabolic workup, which should include biochemistry and which must include 24 hours urinary calcium values also. So I think there is a changing perspectives of nephrolithiasis from an isolated disorder to a systemic abnormality. A complete endocrine and metabolic workup is required so that we are not missing at any underlying abnormality. Thank you all for your patient hearing.
Thank you, Dr. Sameer, that you brought out a very common problem, and so often we are wrong because we have not applied ourselves to the underlying metabolic story before, and we are in a hurry to refer him so that we believe no damage may be done, but we do more damage. What Dr. Sameer has stressed upon is that amongst the 4 types of stones, the calcium struvites and the oxalates, urates, these are your underlying factors that one should be looking for, the corresponding risk factors. And during this deliberation, he said that androgens in males may be responsible. Sameer, is it not that amongst the 4 group, urate forms a big group, and it is the estrogen which is a uricosuric effect, and that's why the females have a less number or less frequency of the stones, but once they achieve menopause, the frequency of males and females remain the same. This is one point I want to raise upon, rather than stressing on the androgens, because androgens are unlikely to affect the calcium, struvite and the oxalates, as I see. The second is so often there is this complete profile or get the all test done, and so often majoritarily 90% vitamin D is less, and we start the journey with vitamin D, how frequent, some say weekly, some say monthly, and there is no choice. And what Sameer has just stressed upon, we are inviting a trouble if we are not hydrating ourselves. Your comments on that?
Exactly, sir, you are right. Yes, those estrogen stories seems to be true. I searched for the literature also, didn't find much of the data onto that why the incidence of renal calculi seems to be more in males as compared to females, especially once you cross age more than 40. And one of the things was this story for estradiol, testosterone, and also maybe males are secreting more oxalate in the urine, but why is it happening is still we are not clear into it. And the second part you put was
vitamin D.
Vitamin D, yeah, very important that it's important that we look for vitamin D. We avoid using injectable vitamin D, and whenever we are giving replacement therapies of vitamin D or calcium tablets, it should not be containing calcitriol, and we should be targeting vitamin D around 30 nanograms per ml. Once you are giving injectable vitamin D, your vitamin D suddenly crosses around 60 to 80 nanograms per ml. Sometimes we see these reports also. And this is again one of the myths that once the patient is having renal calculus, do not stop taking calcium in your diet. That's very important. Of course, avoid taking calcium tablets, but do take a proper calcium in the diet. Until and unless anyone is taking more than 1500 milligram of calcium from the diet, which we say avoid, particularly in patients of hypercalciuria, idiopathic hypercalciuria. In fact, in these patients also of idiopathic hypercalciuria, we tell them not to limit their calcium intake in the diet. You can take calcium around 800 to 1000 milligram per day. That should be the one which should be prescribed. In fact, not taking calcium in the diet will predispose them to further oxalate stones.
Well taken.
Thank you, sir. Now, 1 to 2 questions from the floor, sir. We are becoming late.
Patient who have got hypercalciuria, and if he has got hypertension, we should give these fellows hydrochlorothiazide.
Exactly, sir.
With That is very useful, that prevent the calciuria, at the same time retain the calcium, and very useful.
In fact, patients, even if they do not have hypertension, for idiopathic hypercalciuria, there is limited treatment options. We ask them to take a low protein diet, and that also it should not be animal protein, and plus good hydration. At least patients should be producing 2 liters of urine. That is very important. And third, use of these thiazide diuretics, at least 25 milligram per day of thiazide, and you can increase up to 50 milligram per day. So that should be the drug of choice for idiopathic hypercalciuria. And of course, as sir has said, if the patient is having hypertension, it becomes a drug of choice.
Dr. Samir, a very quick question from me. How we label the patient suffering from recurrent calculi? Because most of the patients we know in the practice, they come only for renal colic. They will come for 1 to 2 times. Then again they come when they have a pain in abdomen. So what are the criteria? Because the stones will be there. How we diagnose that this patient is having the recurrent calculi?
Patients will give you history of recurrent passage of stones. You can see for the scans also whether the patient is still harboring renal stones. So that is the only thing which we usually rely upon.
Thank you, sir. Thank you very much
Thank you,
for
sir.
a very informative talk.